Ladies and gentlemen, welcome to MedSynapse podcast series, your getaway to the latest medical insights. Today, we're delving into a very critical topic, hormonal imbalances in polycystic ovarian syndrome. And guiding us on this enlightening topic is Dr. Nimmi Rastogi. Dr. Nimmi Rastogi is the esteemed CEO and Chief Consultant Obstetrician and Gynecologist and Fertility Specialist at Sarthak Medical Centre in Delhi, India. With over 2 decades of experience, she's a true icon in her field. Dr. Rastogi is not just an expert. She is also an active member of professional bodies like the Federation of Obstetric and Gynecological Societies of India and the Breastfeeding Promotion Network of India. Welcome, Dr. Nimmi.
Thank you, Megha. I'm so happy to be here.
Thank you so much for being part of our MedSynapse podcast series. Now, before we begin, I would like to ask one personal question. Dr. Nimmi, with your impressive career, we're very curious to know what inspired you to choose the path of obstetrics and gynecology.
Okay, so I've been restless from the beginning in the sense that a lot of energy, a lot of hands-on work is what keeps me happy. So when I worked in OBGYN as rotational posting as part of our medical education program, I found that the maximum amount of work you are allowed to do was OBGYN because ours was a OBGYN specialty medical college. As in, it was essentially a medical school with a hospital dedicated to obs and gynae. So much was allowed to us to conduct. Like in third year of medical school, we were allowed to conduct a delivery, an actual delivery, and then episiotomy stitching, then dilatation and curettage, and in final year, we were doing rather assisting for cesarean sections, and in residency jobs we were actively doing hysterectomies. So I made up my mind that this is one field where so much of skill can be put to use, and like one after the other cases, and it was a lot of fun. So that is why I chose vis-a-vis an academic subject like biochemistry or physiology, where more of like academic stuff, the theory stuff was there. I prefer practical aspect. Does that answer your question?
Yes, perfect. Okay, now I'll continue. Dr. Nimmi, thank you so much for sharing your experience and the reason why you chose the path of obstetrics and gynecology. I'm sure your dedication and passion for women's health is shining through in your work, and we're grateful for your expertise in today's discussion. Now, without further delay, let's begin with our podcast. Dr. Nimmi, to begin with, diving into this complex aspect, could you explain the role of insulin resistance in polycystic ovarian syndrome and its impact on hormonal dysregulation?
So, polycystic ovarian syndrome, or as we call it here back home, polycystic ovarian disorder, it is a complex hormonal problem where insulin resistance plays the most important role. So what happens is, as everybody knows, insulin is produced from pancreas, and that that is required for the sugar levels to sustain or maintain. That is a basic energy that we use. So what happens in a PCOS case, that body is not able to utilize as much insulin, so it is not effective, as in the insulin is not effective. So the body forces pancreas to produce more insulin because of insulin resistance, and that excess insulin further unleashes a cascading effect, leading to complex hormone disorder like more of androgens in the body and low-grade inflammation and likewise. So that is how the whole thing begins. So insulin resistance lies at the core of the causative factors for polycystic ovarian disease.
Dr. Nimmi, now let's get into the heart of PCOS symptoms. How do androgen hormones such as testosterone play a role in PCOS-related hormonal imbalances and the resulting symptoms?
So, as part of the new guidelines, ovarian dysfunction as well as hyperandrogenism, that is excess amount of male hormones circulating in a female's body, these are the two pathognomic features of PCOD. So there is excess of testosterone, testosterone. I mean, basically androgens are high. That leads to symptoms like facial hair and hirsutism, and then male pattern baldness, oily scalp, acne, and in some cases even hoarse voice. So it is the excess amount of androgens where they shouldn't be high, like it's a female body. So feminine hormones should be predominant. But in the case of PCOD, because of insulin resistance, there is more quantity of testosterone and androgens circulating, leading to symptoms like acne, as I mentioned, hair loss, dandruff, and all kinds of thick skin, and the non-feminine symptoms that we see in PCOD cases. That is the origin of that.
Now, when it comes to diagnosis, there is a lot to consider. Could you elaborate on the interplay between luteinizing hormone and the follicle stimulating hormone ratios in PCOS and its significance in diagnosis and management?
So, as I mentioned, PCOS is a complex hormone disorder, and the whole spectrum of hormones are disturbed. So, when we try to diagnose, we check the menstrual hormones on day 2. That is the second day of menstruation. So, we check FSH, follicle stimulating hormones, luteinizing hormones, estradiol, testosterone, even thyroid is tested, DHA is tested, and we realize that in most, not all, most PCOS cases, LH is raised and FSH is either low or normal, so the ratio is affected. So that makes us reach at a diagnosis, but we have to substantiate it with other parameters. Like these days, AMH is considered to be an important lab diagnostic component, as well as sonography, transvaginal scan or a transabdominal pelvic scan. So in PCOS, LH is mostly raised, and testosterone levels are sometimes raised, sometimes they're not.
Moving on to our next question, what strategies do you recommend for managing the excess production of androgens and restoring hormonal balance in PCOS patients?
So that is an important part, that we first, sensitize cells to estrogen, because the basic cause is that since there is excess insulin in circulation, increased production of testosterone and the androgen hormones is happening. So we have to do something about insulin resistance, and for that we very commonly start using substance like metformin, and also lifestyle modification, which leads to, if practiced well, it leads to weight reduction, and that everything starts falling in place, and then the androgen levels are reduced. There are some herbal substances also people give for things like male pattern baldness, etc., but I am not in favor. We must always strike at the cause of high circulating levels of male hormones, then treat the symptoms standalone. So I mostly give metformin, And we also give a lot of nutraceuticals like, there are a whole lot of vitamin D, zinc. They say that there is role for these substances, also myoinositol, D-chiroinositol. So we also give that. But the crux of the treatment lies with metformin. There is another medicine lately, incretin. We are studying the effect of that, but it's still in the research stage.
What about when it comes to birth control pills and PCOS? Like, how do birth controls help with PCOS symptoms?
So what happens is when we want to give a a break to ovaries from incessantly producing immature follicles, leading on to formation of these cysts. So giving a combined hormonal pill like oral contraceptive pill or pill containing cyproterone acetate, it does lead to not allowing ovulation and not allowing follicle to kind of grow and get it doesn't get developed into a cyst, because immature follicles are what the cysts are made of. So by giving these things, we are able to slightly reverse the pharmacology of this disease, and the ratio starts getting connected. The androgen hormones also start coming down. But this is in conjunction with other medicines, as I mentioned, and of course the lifestyle modification, losing weight, etc. But OCP has a very important role to play.
Now, fertility is a significant concern for many people. How does hormonal imbalance in PCOS relate to issues of fertility? And what are the primary strategies for addressing fertility concerns in these affected patients?
So you rightly said that it is the fertility which is mostly it's playing on the mind of people. So they come to us, and that's when we diagnose them with PCOD. While it is lately said that the early diagnosis of PCOD is what gives us better results. But yes, because there is problem with ovulation, obviously because of immature follicles, and also since ovulation is affected, so fertility is affected. It's not the rule. It's there are exceptions to that. Some people with the milder spectrum of milder side of the spectrum do ovulate, and they conceive normally without any assistance. But yes, because of these hormone imbalances, ovulation is affected, and even if the ovulation is happening, sometimes it is not that strong to get fertilized by sperm, and even if it gets converted into an embryo, sometimes there is implantation failure, so increased rate of miscarriages, even gestational diabetes is seen sometimes, and pregnancy-induced hypertension is also seen. So a whole lot of problems. A full-term pregnancy rate is low with people who are struggling with PCOD. So it's a good idea to get under care of a gynecologist from the beginning if you're planning a baby and you suffer from PCOD.
Now, moving on to our next question. Let's broaden this perspective now. How does thyroid health affect PCOS, and why should we care about both?
Yeah, I often have seen the combination of thyroid hypoactivity and PCOS. In fact, it is a rule to check thyroid stimulating hormone and free circulating T4 along with the menstrual hormones, because they seem to coexist, and that is what compounds the whole issue. And there is low-grade inflammation, which may lead to that, the positive factor behind both, or it could be genetic predisposition to hormone imbalance, including thyroid problem, as well as this because thyroid has a significant role uh, in menstrual regulation and formation of an ovum. So there is an integral role that thyroid gland plays, and the underactivity of this gland does make the PCOS worse.
Now, let's move on to our final question for the day. Looking towards the future, what exciting research or treatment approaches have you come across that show promise in addressing hormonal imbalances that are specific to PCOS, and how might they impact the patient care?
So, a lot of research is going globally on PCOS because it is such an important. In fact, rather bulk of our patients now belong to this spectrum, and it has bearing on your adult life. Not just the early reproductive years, but when you grow old, if you're a PCOS, you can suffer from metabolic syndrome, hypertension, diabetes mellitus, endometrial carcinoma, a whole sort of thing. So it's a good idea to find more and more on the causes as well as its management, effective management and reversal. So I would say that India is also part of this kind of, doing a lot of studies on PCOS patients. So, two of the studies I know, and of course, India has just recently revised the guidelines. So, we say that early diagnosis should be there. We should not delay. We should not delay till the time a girl is married and trying to raise a family. And that's when we realize that the person is having problems with ovulation. We should resort to early treatment. That is the essence of the research. The second thing is that lifestyle modification should be the forefront. It should be at the forefront of management. It should not be an adjuvant management, apart from, of course, using metformin or oral contraceptive pills or cyproterone acetate. It should be the mainstay. There is a definite link up between weight gain and PCOD, and it's vice versa. There's a cascading effect. So we should motivate our patients to get into the ideal range of BMI, lose weight, stay active, save themselves from stress. The role of sunlight is highlighted, and of course omega-3 and omega-6 fatty acids. Then there's a new research that says that in the young age, we should do AMH also, the testing of AMH. Because AMH, previously we used to do it only when a person is desirous of having a baby, because that gives us indication of the fertility. But now we realize that AMH could also be an important clue to diagnosis of PCOD in the early in the teens, say about early teens or late teens. So that's another research. The third thing is PCOS patients they have less circulating incretin. It's a hormone. So that has given us a clue that we can manage PCOS better with availability of this incretin hormone, or fortifying our treatment with this. So technically, the basic is same, but more and more importance is being given to early diagnosis and aggressive management. Don't leave it and live with it. Don't tell your patients that we don't know what causes it and we don't know how to manage it. You just lose weight and that's it. No, there are many interventions that you can do as physician, as OBGYN. And life can be lived normally. Fertility also is it's a treatable cause of fertility. It is not very hard to allow a patient with PCOS to conceive a baby either naturally or with assisted reproductive technology. Right? And we should also tell them about this potential risk of endometrial carcinoma and other chronic disorders like heart disease, like hypertension, like possibility of developing diabetes mellitus. So we should tell them and prepare them and motivate them to actively manage their PCOD and not sit over it, right? So at my end, that's what we are practicing, and we await results of many other ongoing research and studies. And I'll be very happy to know what else is happening globally. Yes, of course, the mental health is also to be integrated with your cardiovascular health as part of your PCOS syndrome. So that's another of the add-on. The mental health, stress, anxiety, depression, these are all part of the spectrum of PCOS symptomatology. So now we are better informed, better equipped to counsel a patient with PCOD.
Dr. Nimmi, we extend our heartfelt appreciation for your invaluable insights and expertise in sharing and being part of today's conversation on this very important topic. Thank you so much for your time and dedication to advancing medical knowledge on our platform.
Thank you, Rega. Pleasure's mine. So nice to connect with the audiences through this podcast. And it's a two-way learning process. Patients teach us, and we are able to help the other patients.
Thank you so much once again, Doctor, and looking forward to many more wonderful podcasts together. Welcome to our MedSynapse family.
Absolutely. I'll be more than delighted to appear.
Thank you so much. And to all our dedicated listeners, if you found this episode enlightening and wish to stay informed about the latest medical discussions led by our esteemed experts, we encourage you to like, subscribe, and register on our MedSynapse website. Until our next enlightening discussion, we offer you sincere thanks and see you soon again. Goodbye.